Okay.
Introduce yourself, please.
All right. Hi, everybody. I think all of you kind of know me by now, but my name is Sharon Myers, and I'm a nurse, and I've worked with Linda for years over at the Med Center in cardiac rehab and then heart failure. And now I'm going to be working here on every Tuesday. So happy to be here, and thank you all for coming. So today, Linda asked me to talk about diseases of the heart, and this was actually taken from a lecture that Dr. Kepagoda used to give, and I just updated it a bit and changed it around. So ask questions as we go along if you have any questions. So we're going to talk about the different diseases of the heart. So you have to think of it about what could possibly go wrong with the heart. So I want you to think about the heart as like a house, right? So if you had a house, you've got the exterior part that goes around the house, right? The walls, the plaster, all of that. And that's kind of what the outside of the heart is. It's got a muscle layer, which is like, you know, the drywall. And then inside the heart, there's 4 different rooms, basically. There's 2 rooms on the top level and 2 rooms on the bottom. Top level are the atria and the bottom are the ventricles. So kind of 4 rooms. And then also going around the heart and into the muscle, you've got an electrical system, right? Just like a house, you've got electricity going into it. And then between the rooms, what do we have between our rooms at home? What do we use to go in and out of the rooms? Doors. So you've got doors inside the heart, and they're called valves. So something can go wrong with any of these areas. Something could go wrong with the valves, something can go wrong with the muscle of the heart, something can go wrong with the drywall that's going around the paint area, and something could go wrong right in the muscle. So we're going to talk about all those different areas of the heart and the different things that can go wrong. So this just lists them all. I'm going to talk about diseases of the heart muscle, disease of the valves, diseases of the arteries, diseases of the covering of the heart, and diseases of the electrical conduction system. It's a lot of stuff. So some of it I'm not going to spend too much time on because some of it is a lecture in and of itself. All of these things, if you have one of these things, it causes the heart to not be able to work as well, which is the whole problem. And then we get symptoms, short of breath, fatigue, tiredness, chest pain, a number of things. But all of these things, one or more, can cause a problem with the heart not being able to function as it should, and then can cause you to have symptoms and not feel well. So the first thing I'm going to talk about is disease of the arteries. So the arteries are kind of like your plumbing in your house. They bring the blood to the heart, take the blood away from the heart. And the most common thing that can happen with the arteries is something called atherosclerosis, or it's a development of plaque on the inside lining of the arteries. And you can see up there, this artery at the top is just starting to get a little bit of plaque in the artery. What causes you to just start to get a little bit of plaque in the artery like that? Cholesterol, right? If you've got a lot of the bad cholesterol, the LDL cholesterol, cholesterol gets carried around almost like on a little train. And if the cholesterol gets attached to the LDL, then the LDL keeps it in the blood. And if you have a lot of cholesterol in the blood, it causes an inflammation on the inside lining of the arteries. So having a high cholesterol, eating cholesterol, or being a person who just makes a lot of cholesterol and it keeps circulating, that's one of the primary causes that cause you to start laying down plaque. Once you get a little bit of inflammation in there and a little bit of plaque, even more inflammation occurs. It's like, I've got a cut right now, but I'm not going to take off my Band-Aid to show you, but you know how when you get a cut, if you look at it around the edges of the cut, you know how it's kind of red, it can be a little bit swollen. Same exact thing happens on the inside lining of your arteries. So they get inflamed. That's what we all are talking about, inflammation, inflammatory. We try to take medicines that cause anti-inflammation, and we eat foods, especially here, that are anti-inflammatories. Debbie talks about all those foods. So that's what you want to avoid, is getting this whole thing started. Because once it's in there, it creates almost like a rough spot. So you know, like in a river, if you've got like a little area that's got some buildup of rock and it's got a few sticks, it's kind of a little, the river's flowing down, but there's this little area there that's just got a bunch of mud and rocks and sticks. What happens? Things stick on that little area, don't they? All sorts of things, leaves get stuck in there. Same thing happens in the inside of your arteries. Once you have like that roughened, inflamed area, things just start sticking there. The plaque gets larger. Then once it gets large enough and more and inflamed, your body starts sending platelets there. So it sends blood there to kind of try to heal it, sends these things called monocytes to try to heal it. It eventually even goes inside the wall, which this doesn't show it there. When you're at this point, you know, you've got probably a 50 or more, probably 50% blockage. And that's when it starts getting dangerous because not enough blood can get by to get to your heart, right? So your heart's not getting enough blood and oxygen. And that's when you can start to have things like chest pain, your heart's not pumping well because there's just not enough room to get by those blockages. And then once you gets big enough, you can get a bunch of platelets on there and one of them can rupture and, you know, you can get a pulmonary emboli that they can travel to your brain. So, but the main thing is once it ruptures, it can completely occlude the vessel. Then nothing's getting by to that area of the heart. The coronary arteries go all over the heart. If the left main, which is what they all come off of, if that one gets blocked, then there's no blood going anywhere. So that kind of gives a little prelim of the diseases of the arteries. Why this is not moving forward. Oh. I didn't know these are all going to sneak in like that. So yeah, so the different medicines work in different ways, but the main thing that they do is one way or another, they work to keep the cholesterol out of the blood. So they help to remove it. They act like a HDL train. They just get it out of there all the time. Some of them prevent you from making so much cholesterol. They just work directly on the liver to stop that. We talked about all that. So that is a good picture. It shows the coronary, all those little veins on there, the coronary arteries, and they sit on the top of the heart and they bring the blood to the heart, and the heart muscle cannot function if it weren't for those coronary arteries bringing blood and oxygen. So if you do get a blockage, sometimes even with, you know, 70% blockage, not enough blood is getting by, you can have damage to your heart or have a heart attack. But especially if you have a complete blockage, you will have a heart attack. A heart attack means that not enough blood and oxygen got to a certain part of the heart. So this one right here, this is probably the artery called the left anterior descending. It comes right down the left side of the heart on the front of the heart. And you can see that it supplies blood to right here, the left ventricle. And so if this got blocked up here, say, then no blood would get down here. Then this whole area of the heart, you can see how it's kind of a different color. It doesn't get blood and oxygen. And if it doesn't get blood and oxygen for too long, you'll actually have death of that muscle and scar tissue, and that will not come back. So that's why if you're having chest pain or angina, you want to get to the hospital right away, because if they catch it early, they can take you, it's pretty quick. They take you right to the cath lab. They open up that blockage. They put a stent in there, and you prevent having that long-term scar tissue and damage to your heart muscle. That's why it's important not to sit around wondering if you're having chest pain. If the only way to tell if your chest pain is a cardiac is to go, you know, have some blood drawn, get an EKG. Warning signs and symptoms of blockages in the coronary arteries are chest discomfort. It can feel different to different people. So in some people, it might feel like a elephant standing on your chest. Some people, it might feel like a dull pain. Some people, it's sharp. It can be other places besides in your chest. It can be up in your jaw. It can be down your arm, your left arm in particular. Some people just feel short of breath. They don't, especially people that have diabetes. Their nerves are just not as sensitive as others from the diabetes. And so instead of having chest pain, they just may feel short of breath. Lightheadedness, many times associated with feeling nauseated or throwing up, but not always. The pain can feel like pressure here, but then it kind of feels like it goes through to the back. So sometimes just upper back pain. And I already talked about left arm pain. What are the things that can cause you to be more likely to get these blockages? We already talked about high cholesterol, right? What besides your diet, what besides high cholesterol do you need to watch for on your food labels? Look for the amount of cholesterol, but what other type of fat do you want to avoid? Yes, saturated fat, right? So you look for things that have more of the monounsaturated fats rather than saturated fats. Having diabetes also puts you at risk for getting these blockages, being overweight, having high blood pressure, stress, smoking. All of these things have one thing in common, all the things that put you at risk. And the thing they have in common is that they all cause an inflammatory state on the inside lining of your arteries. Stress causes you to have more stress hormones, epinephrine circulating, and it causes damage to the inside lining, causes an inflammation. Same thing with diabetes, same thing with being overweight. High blood pressure causes that inflammatory response. That inflammatory response is the thing that starts the whole cascade of things. Okay, also going to talk about, besides coronary artery disease, there's other diseases of the arteries, and one of them that have nothing to do, well, they do have a little bit. If you have a high cholesterol, you're more prone to having aneurysms. But aneurysms can occur mainly in the thoracic area where the aorta runs down through, or down in the abdominal area. So an aneurysm is when a section of that blood artery balloons out. So instead of being, you can see, instead of kind of being straight down, you get a balloon effect. When you get that balloon effect, that wall that's around the balloon thins out and it's more likely to rupture. And if you get a rupture in one of your big arteries in your aorta somewhere, it's very dangerous.
Not a good thing.
Not a good thing. So you can see the aorta is it's a huge artery. It's very important. It's what comes out of the aorta comes out the top part of your heart. It brings blood to your lungs, your diaphragm, all your organs. It comes down through your chest area. That's called a thoracic aorta. And then it goes down into the lower part of your body. It goes into your abdomen called an abdominal aorta. And then it branches out into the iliac vessels. So you could get an aneurysm in any of these places. The most common place that people get aneurysms is abdominal aortic aneurysms. Those are very dangerous. You can also get them in your iliac arteries. Those are less dangerous, but still you want to get help right away for those. So they occur in the two main places, in the abdomen or in the thoracic area. What puts you at risk for getting an aneurysm? Plaque formation. Plaque formation, once again, because you have this whole inflammatory response, which damages the aorta. If you get a little plaque there, like you did in the coronary arteries, if you get a plaque there, then a blood clot can form there, go there to try to heal, and once again, break off, travel to your brain and cause a stroke. So you can have strokes just from having an aneurysm. And sometimes if you come in the hospital with a stroke, they will check you to make sure if you have, to see if you're having any aneurysms. The aneurysms, if they get large enough, can press on other organs and cause you to have pain there. If you have an aneurysm rupture, you definitely will know that you're having it because it causes pretty bad pain. And you want to get to the hospital right away. So main causes of aneurysms are atherosclerosis, or those plaque buildups, having high blood pressure. You can have many times aneurysms are caused by just a genetic congenital predisposition. So you're just born with like a small area of either in your brain or in your abdomen or your thoracic area of just the vessel. It just has a weakened spot in it. You're just born that way, and over time, it just gets worse and worse. So more common as you get older. And then syphilis used to be the common cause of thoracic aneurysms. but not as much anymore, although syphilis I've heard recently is making a comeback.
Oh,
Yeah. So we talked about, I'm not going to go through all this again because we've got many more slides, but you can get a bulging of the aneurysm and then it can burst. You can also get it so that the wall, when it becomes thin, it kind of becomes fragile and little fissures open up, and then blood can get in the wall, and then that can cause it to burst. Okay, so the next part to talk about is actual diseases of the heart muscle. So we talked about, basically, we talked about the plumbing of the house. Now we're going to actually talk about the walls of the house. So this is kind of the way the blood comes in through the aorta, goes into the right atrium, into the right ventricle, then into the lungs to get oxygenated, then back into the left atrium, and then down into the left ventricle. So if you have trouble with the muscle or the wall of your house, then the heart is not going to be able to squeeze well. In order for blood to move around like that, it's got to be able to relax and fill with blood, and then it's got to be able to squeeze well to pump it. If you're having a problem with the walls of your house, the blood is just going to sit there. It's not going to be able to move around correctly. So one of the most common causes, one of the most common diseases of the heart muscle is heart failure. It means that the heart failure is a very dramatic term, but it just means that the heart is not able to pump blood effectively in order to get out of the heart, around the heart, to get out of the heart, to get to the brain, to get to the rest of the body. Almost 6 million Americans have heart failure, very common disease, especially as we get older. Most times if you get heart failure, it's considered a lifelong disease, although we do have new medicines now that can actually improve the heart muscle function, which is great. And it's an area of a lot of study going on heart failure because so many people have it. So there's two, I'm not going to give a whole lecture on heart failure because I think I just did that like a couple weeks ago, but I'll just go through these quickly. So you can have heart failure on the left side, you can have heart failure on the right side. And the reason we distinguish between the two is because they're treated a little bit differently. They have different symptoms, and you may be on some different medicines for those. Also, it can be divided into something called systolic heart failure, which is also called heart failure with reduced ejection fraction. It just means that in systolic heart failure or heart failure with reduced ejection fraction, it just means the heart doesn't squeeze well. Instead of going like that when it pumps, you hear the lub-dub, it's kind of going, it's just ineffective squeezing. If you have diastolic heart failure, the heart is able to squeeze well, but it doesn't relax. Right? You can't have blood going into your heart if it's not relaxing. If your heart's like this, blood comes in there, it can't really get in there because the heart's not relaxing well. So the heart has to relax and then squeeze well, relax, squeeze well. So you can have a problem either with the squeezing part or with the relaxing part. Either way, the amount of blood that's going out to the body is going to be diminished when you have heart failure.
and these are typically more left-sided heart failure hearts, right?
It could be either. Yeah. It could be either. So symptoms of heart failure many times will develop slowly because the body kind of tries to compensate for these. But the main symptoms are shortness of breath, having a cough, especially at night when you try to lie down flat in bed, needing to use extra pillows in order to breathe well at night, swelling in your legs, arms, abdomen, weight gain from the fluid retention, feeling fatigued. Also, chest pain. Sometimes you might have irregular heart rhythms. All those, when you come in with chest pain, when you come with irregular heart rhythms, they're going to check you out for all these things. They'll check you out for heart failure. Look at all the causes of heart failure. A lot of causes. Anybody have heart failure and know the cause of the heart failure that they have?
SVT and heart failure.
We're going to talk about SVT. A question was, is SVT heart failure? SVT stands for supraventricular tachycardia. It's a problem with the electrical system of the heart. And if you have it long enough and frequently enough, it can cause you to have heart failure because it's making the heart work so hard because you're pumping so fast. But getting it under control with medicine you will not have the heart failure.
I only had it one time.
Well,
And it was nearly dead. They had to stop me on.
it was very fast rhythm, it sounds like.
Pardon?
It was a very fast rate. Yeah, we'll talk about, we'll get to that. But yes, that brings up heart arrhythmias can cause heart failure if you have them over a long period of time and they're not able to get you out of it.
And how would it you can talk about
Yeah.
it then, how it comes on so suddenly and I've never had one.
Yeah, that's good. We'll talk about that. Anybody else know of something that would cause heart failure that maybe you've had or friends has, you've heard about?
The heart.
Heart attack, number one. Heart attack, most common cause of heart failure, right? So,
Bad idea, John. It was one of your worst decisions ever in
Yeah.
life.
bad choice, right? Yes.
My dad.
So yeah, heart attack, getting the blockages in one of those coronary arteries. So blood can't get through to the heart muscle. The heart muscle dies. When heart muscle dies, it can't contract well. So it's a problem with the ability to contract. Anyway, problems with the heart valves, having high blood pressure, those arrhythmias, having cancer therapy with radiation or chemotherapy can make you more likely to develop heart failure down the road, usually 10, 20 years later. Because the chemotherapy and the radiation can actually damage the heart muscle. It gets rid of the cancer, but it also damages some other things. It's pretty strong stuff. Having viral or bacterial infections. Sometimes women during the pregnancy will develop heart failure. Drug and alcohol abuse. Methamphetamine now, we used to never see young people coming in with heart failure, very few of them. And now because of the meth epidemic, methamphetamine works directly on the heart muscle to cause damage, and people can end up with heart failure from that. And cocaine, methamphetamine and cocaine, alcohol abuse. So I'm not going to spend a lot of time on this slide. How do you diagnose heart failure? You come to see your doctor, you may have symptoms, and then they'll do an echocardiogram, or they can actually see the heart relaxation, its pumping action. They can see if it's enlarged, if it's thin somewhere. Also nuclear imaging, CT scans, or MRIs. So another disease of the heart muscle is called myocarditis, where it's just where the heart muscle gets inflamed. So you can see the picture there, the heart muscle's kind of reddish colored, and it's once again the same thing as if you get a cut on your hand and you see the redness around it, or if you pull a muscle in your leg, or you get a shot in your arm and the muscle that you got the shot in is just sore and inflamed. So that's the same thing that can happen in the heart muscle. It's called myocarditis. It's usually caused from viruses, including COVID-19. So that's sometimes people who have long COVID may experience myocarditis or another around the lining called pericarditis. So diseases of the valves. So the valves are like the doors in the house. It's how you get from one room to the other. So there's basically 4 valves in the heart, and they, as the same as with a door in a house, they open and they close. And a door in a house, you leave it open, not much bad happens. But if your valves in your house don't open and close correctly, then you get blood going where it shouldn't be going. So you want the valves to open so to let blood in, then you want them to be able to close to keep the blood in so it can go to the next place it's supposed to go. So it's supposed to go from the right, it's supposed to travel from the right atrium through the tricuspid valve right there, through the pulmonic valve into the lungs, back into the left atrium and then into through the mitral valve into the left ventricle and then out the aortic valve to get to the heart. So 4 valves, 4 doors, basically. And thank you to Ivan. I'm going to try to show a picture of the valves working. So I just click on this.
And that's where you put it? Or did you make it on the next slide? Oh, no, this is the one that,
Oh, that's the other one.
that's the other one.
Oh, okay. Well, this, well, I'll show you both. So this just kind of shows the blood, it's coming into the right atrium and then going into left ventricle, into the lungs, back into the heart. But there's a better one on the next page, I think.
So you probably have to hit escape. Or you have to go back to your here. Here.
And then go to the next slide. And click on it. It's a cool picture, isn't it? So this really shows it. It shows the blood coming in, going through the trach. See that valve right there? You can actually see the valve. It's very cool. So you can see the valve opens up and then it's got to be able to close. If it didn't close, the blood would try to go right back up, right? And then it wouldn't be able to keep moving because in the next place it's supposed to go from the right ventricle is where?
To the lungs.
Into the lungs, right? So it's got to go through the pulmonary valve. So there's another valve. See that very well.
I like how it's jumping out and going up back into the aorta at the top there.
This right here, I think it's going into the pulmonary valve. This one right here is the mitral valve. And you can see right there too how it opens and closes. So that's the way it's got to work. So if you have a problem with the valve, sometimes the valves just get what we call leaky, and sometimes they get kind of stiff. But either way, they just don't open and close correctly. The blood does not move through the heart correctly. If the blood doesn't move through the heart correctly, then you can get enlargement of the heart, but you also, the blood doesn't get out to the rest of the body correctly. So if you have a little bit of stenosis or a little bit of leakage, your doctor will kind of just watch it for a while. And they wait until it gets to a certain point, they measure it. And at a certain point, they know that your heart may start to enlarge and then it's going to start to affect the rest of your body and cause you to have symptoms. And that's when they'll treat it. Okay, so in general, 2 kinds of things that can happen with valves. Either they can get stenotic, which means that the valve is just stiff, it doesn't open up all the way, or they're flappy. They don't close well and the blood just regurgitates back up. When the valve is stenotic, you can see down there on the left, it's just stiff. It just doesn't work well. Another picture showing, I have better pictures than this. You guys have already seen the better pictures than this. So they have all sorts of, you give a 2-hour lecture on this, but they've got all sorts of treatment for valve diseases. Used to be when I first started taking care of patients years ago with heart valve problems, there was only one thing that we did, and it was to put in a mechanical valve, which you could even hear it clicking in people's chests, right? And you had to take blood thinners for it. And, you know, it was a whole thing. Then they started doing tissue valves, which when you're going to have a tissue valve, a surgical taken in, put in surgically, you didn't have to take blood thinners for that. Now there's all sorts of things, and those were all done by cardiac surgeons. They had to open up your chest. Recovery time was long. The surgery was dangerous. But now they have procedures that many of the cardiologists called interventional cardiologists can do. They can just sometimes, if the valve is stenotic, they can just go in through your groin up into the heart, inflate a balloon in there and kind of open it up. It's just like pressing it open again. And those do work well. The problem is they only last for about a year, and then you'd have to get it done again and go through the risk again of that. So, you know, they use those in some cases, but not so much anymore. And then they can do what's called a transcatheter aortic valve replacement. And they're also doing these in places besides the aortic valve. Now they're doing them experimentally in the mitral valve and the tricuspid valve. But what they do is once again, they just float a little catheter in through your groin, They go into the valve area and they can actually, they don't remove the valve, they leave the valve there, but they just have this little, they just stick a little valve in there and it just adheres and eventually it just kind of endothelializes into the area and it works like your valve. Very cool. The mitral valve, they do a little procedure called a mitral clip where they, if the valve, if you got flappy valves in the mitral valve, they just go in and they put just like a little clip on it and it clips the little leaflets together so that they're not flappy anymore. It takes the flap out of them. Blood can still get through there, but they're not as flappy. And all sorts of new things are coming out with these valves. And these things, you know, it's like getting a cardiac catheterization. So the risk is lower, much lower in getting these kinds of procedures for valves. And then there's all, we talked about the diseases that affect the actual valves. We talked about the diseases that affect the actual rooms of the heart and the muscle, but you can also get a disease that affects the outer covering of the house called the pericardium, and it's called pericarditis. And there's just a lining that goes around the heart, and that can become inflamed. It's usually, once again, same as myocarditis. Pericarditis is usually caused from some sort of viral infection that you get that just seems to also attack a lining that goes around the heart. Always when you have pericarditis, you will notice that you have chest pain. You can feel it in your neck, shoulder, back. It can feel like you're having, you know, a heart attack because of the type of pain and the location of the pain. Sometimes increases with deep breathing or lying flat, may increase when you cough or swallow. It can feel sharp and stabbing, may be relieved by sitting up or leaning or bending forward. And with this one, you may have fever, chills, or sweating with it. Can be caused by cancer, anything that really causes an inflammatory state, you know, in your body can cause pericarditis. Any disorder which attacks your immune system can cause you to attack healthy muscle as well. That can happen. Can happen in thyroid disease, kidney failure, more common in rheumatic heart disease. You can get pericarditis if you have a heart attack because the whole heart is inflamed, including that lining around the heart. It's common to happen after heart surgery. If you have bypass surgery, you can end up with some pericarditis for a period of time that they have to treat. Also, if you get radiation therapy to your chest, you can develop pericarditis. So the treatment, I'm not going to spend a lot of time on these. First line of treatment is non-steroidal anti-inflammatory drugs. Also a medicine called colchicine. If they know that you've caused from a bacterial infection, they'll give you antibiotics, may give you antifungal medicines if they feel it's caused from fungus. I've seen many patients who are resistant to these kinds of things be on really high doses of prednisone for a period of time. And then they may have to go in and use a needle and remove some of the fluid that is in the sac around the heart. Sometimes they actually cut a little hole if you have an infection there so that the infected fluid can drain out. Do not continue to get reinfected. And sometimes they have to actually remove part of the sac that goes around the heart called the pericardectomy. So diseases of the conduction of the heart, and you were talking about SVT, so we'll talk a little bit about that. So just like your house, the heart has an electrical system. And just like your house, sometimes your house electrical system goes haywire, doesn't it? Sometimes it doesn't work. Sometimes you got lights flashing, all sorts of things. I have a weird thing in my house right now where if I don't have my living room light switch turned on, the light in my bedroom, in my daughter's bedroom, will not go on. But if I turn on the light switch in the living room and then she turns on her light switch, it'll work. So it's kind of like heart block. I'd say it might be kind of like heart block. Yeah. So you can have all sorts of problems with your heart conduction system. You can have conduction problems that cause your heart to go really fast. You can have conduction systems that cause your heart to go, conduction problems that cause your heart to go slow. ones that cause your heart to beat irregularly. So instead of hearing the lub dub, you'll hear blub, 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 dub, 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 pause, dub, dub, lub, all that sort of thing. And then you can hear skip beats where it'll just go along fine. You'll hear bloop, da, 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 bloop. You can feel it if you're taking your pulse. So those are the main kind of 4 categories of problems you can get. What should happen is the SA node should send a message through the 2 rooms at the top, the atria. It goes down into the AV node, and then in a consecutive manner, the message goes from the AV node out and causes both ventricles to beat synchronously. That's how you have the best, strongest cardiac output. If they're beating together. Atria beats together, ventricles beat together. But things can go haywire in that. So that's what normal conduction looks like. And that's what the EKG looks like if you're having normal conduction. The first little blip there, this little called the P wave, that's your atria contracting. The bigger wave is the ventricles because they're bigger. The bigger wave is the ventricles contracting. So you brought up SVT, so got a slide for you. So one of the common fast heartbeat or fast rate conduction problems is called SVT, supraventricular tachycardia. Supra means above, so it happens above the supraventricular. So it's above the ventricles. So what's above the ventricles? What are these little guys called?
Atrium.
The atrium, right? You guys knew, you just were afraid to say. So these are the ventricles. Supra, above the ventricles, are the atria, right? And that's where the heartbeat usually starts, is up in there, and then it gets transferred to the ventricles. So what happens up there is that instead of starting at the SA node and then going down in a synchronous way through the atria, the heart, it's called an accessory pathway, but there's this little electrical, there's little electrical pathways running all over your heart. But usually they just listen to the SA node and they listen to the AV node. But sometimes, as with kids, they just don't listen. They decide that they're going to go off and do their own thing, right? So that's what happens with SVT. An accessory pathway just starts firing. And so if you have an electrical system firing in the atria, it's not going to be synchronous. So instead of it coming from the SA node where everything beats together, and it's trying, the SA node's trying, but this little pathway has gone crazy and it's firing in the atria too. So you're on an EKG, you'll see, everything going really fast. So it's a fast heartbeat. It happens above the ventricles. It's usually not dangerous unless the rate that it's going is really fast. So yours must have been really fast. So lots of times people will have, it's a very common arrhythmia. If we put Holters on all of you, which measures every heartbeat that you have, most people you'd see would have little runs of SVT, which means you might have like a 10-second run. You don't even know you're having it. But if you have this for a longer period of time or the rate is very fast, then you will experience dizziness, lightheadedness, sometimes chest pain, because the heart's going so fast that blood's really not getting out of the heart. The heart, remember, has to relax and contract. If your heart's going really fast on the top, there's not enough time for the heart to fill with blood. So the cardiac output is less. So that's why you feel so lousy if it's going really fast. If you got SVT and it's only going at 130 beats a minute, you probably will feel just fine. But if it's going at, 180, 200, 220, you're going to feel pretty lousy. So some of the treatments that you can try if you know that you're somebody who has that, and you can try initially, is to cause of a salva maneuver. So you want to try to just bear down like that. You can try to blow through like a straw, something, because that causes you to bear down. They also, if you come into the ER, they'll do a carotid massage that can trigger the vagus nerve and cause your heart to slow down. And then there's medicine that they can give you, which is probably what they gave you, some medicine.
Well, she said they shocked her. That's unusual treatment, I would say.
That's unusual treatment for that. And they said it was SVT.
They said it was an SVT, and I know I heard one ambulance driver was continually taking my blood pressure and.
Yeah.
210,
Yeah,
and so. then
that's unusual to do that,
I was
but it
trying-
worked. It must have worked.
It did work.
Yeah.
Like turning on your computer, turning it back on.
Yeah,
They rebooted you.
rebooted you. That's right. Another fast heart rhythm is called ventricular tachycardia. And that one is usually dangerous, although we have had patients that have just been running around with VTAC and they didn't know it because it's going slow. If something's going slow enough, then the enough blood is getting out the heart, the ventricles are able, they have time to fill, and then they are contracting, so enough blood is going out. But usually with ventricular tachycardia, it's going very fast and it's dangerous. So that one you will get shocked for. And one of the common causes of ventricular tachycardia is if you get having a blockage in one of your coronary arteries. It's also common in people that have heart failure because they have so much what we call structural damage to their heart failure, to their heart. Their muscles stretched, it's thickened, the conduction system just can't work the way that it should because of all the structural damage that's happened in the heart. There's another arrhythmia that's very dangerous called ventricular fibrillation. And on the EKG, you don't even see a PQRST, right? All you see is this fluttering or fibrillating. You won't be able to feel a pulse because the heart's just quivering. And there's no cardiac output. And you'll be in trouble very quickly with that one. Slow heartbeat. We talked about the fast ones. You can have something called bradycardia, which is a slow heartbeat. And people can tolerate that usually pretty well. You were talking about, you had a heart rate of 30, right? Didn't you say one time and you didn't even know you had it, right? People were shocked that you felt just fine, right? Yeah, yeah. So you don't always know if you have bradycardia, but usually because if your heart's going that slow, there's less blood going out to your brain, to all your organs, and you'll feel short of breath, dizzy, tired, and your blood pressure will be lower. So sinus bradycardia is, more common than some of the others because it can happen from some of your medicines. If you're on too high a dose of a beta blocker, like metoprolol or carvedilol, that can cause, you guys had that in here, didn't you? Yeah. You got Linda and crew and Mary discovered somebody were they not feeling well?
He was not.
Yeah. So what were his symptoms?
He's just tired.
Just tired, right?
His heart rate was 30.
Right. So when they checked his heart rate, it was 30, it's bradycardia, and it was caused from his beta blocker being on too high dose of the beta blocker. Right. So easy fix, change the dose of the beta blocker.
Patty has a question. Wait.
Well, less than 60 is considered low, but you really won't have symptoms with less than 60. You may begin to have symptoms with less than 50. And in people who are athletes and are well trained, they may have heart rates of 40 and even in the 30s and feel just fine because their heart is trained for that. But in general, I would say a heart rate less than 50. Although, if you're on, sometimes you have to be on these high doses of beta blockers in order to get the result that they want to get from them, and you will have a low heart rate. Yes, so the main thing that they decide what's too low for you is if you're having symptoms. So if your heart rate's 50 and your blood pressure is fine, you're not dizzy, you're not short of breath, you're not too tired, they're going to let you be a little bit tired. But if you're not too tired where you're just sleeping all day long, they'll just leave it there because the benefit outweighs the risk, right? But if your heart rate's 50 and you feel dizzy and your blood pressure's low, then they're going to adjust your medicine. They're going to do something about it.
Excuse me, is that beta blocker or something?
No, it's considered well, people are many times put on it for blood pressure. It's not a blood thinner. It just
Talking about
slows the heartbeat. The question was, is a beta blocker a blood thinner? And I said, no, it is not a blood thinner. It's usually an lowers your blood pressure and lowers your heart rate. It also causes your heart to be able to beat stronger. But usually people are put on it
They put you on blood thinner if you have a heart. The regular heart rate,
if you have atrial fibrillation.
what would they put you on? Blood
They,
thinner?
they would put you on both. If you
Yeah.
were an atrial fib, you'd probably be put on a beta blocker to lower your heart rate. And you'd be put on a blood thinner to reduce your stroke risk.
Yeah.
And in Rich's case, he's gonna stay on the beta blocker to get off the blood thinner,
Because of the procedure he's gonna have done.
because he's taking the beta blocker for more reasons than atrial fib, most likely. Almost everybody in our room is on a beta blocker. I'm pretty sure.
So sometimes if they may need to, depending on what is wrong with the conduction system of your heart, if you have bradycardia, they may need to put a pacemaker in to help to get the electrical conduction system back on track and cause the ventricles to beat in a synchronous manner. You can also be on a pacemaker sometimes if you have fast heart rhythms, because the pacemaker will pace you out of them.
Like there's processes with pieces, but
Mm-hmm.
As you get older, it's more common because you have more problems with your conduction system, just like a little old electrical system in your house, right? Same thing. So we talked about fast heart rates. We talked about slow heart rates. You can also have what we call irregular heart rates, where the heart is the atria and the ventricles are, you're not having that synchronous thing where the atria is not beating together and the ventricles. So atrial fibrillation happens where? Do you think it starts in the atria or the ventricles? Atria, easy question. Yeah, so the conduction problem is in the atria. So there's just, what happens is instead of one spot where the SA node, where the conduction system starts, and going down directly to the AV node, that's what should happen. There's a little, once again, an accessory pathway, and it goes firing off to different parts of the atria, and they start firing off. So on an EKG, it's really pretty easy to see atrial fibrillation. It's one of the easiest ones to see. This is the normal one. You'll have a P, which is the atria, and then a QRS, which is the ventricle, and then recovery. So P wave, P wave, P wave. Look at this one. You can see, look at, there's a lot of P waves there, aren't there? Because there's a lot of electrical conduction going on in the atria. It's kind of firing all over like this. Eventually it gets to this, one or two of them get to the AV node, and then the ventricles contract. So you can see that the ventricles are contracting pretty well, but everything is just irregular because the message is getting through in an erratic way. So it's not synchronous. It's irregular. And when you have this, it can cause, blood is not just going atria, ventricles, atria, ventricles. It's going atria, and it's putting a lot of strain on the atria, and the blood is kind of pooling there because it's not being pumped out synchronously. It can cause part of the atria to try to compensate by pouching out. It's called an atrial appendage. And once you get a little pouching out like that, you can have other problems, which means that the blood's going to pool there. You're more likely to get clots in that area because the blood's just hanging out. If blood doesn't like to hang out, blood is meant to keep moving. If blood hangs out somewhere, it clots. Just like if you get a cut and blood just kind of pools there, clots there for it. So it's meant to clot, but you don't want it hanging out in your heart. You want it moving through. So if you get an atrial appendage and a little outpouching of the atria, blood's going to pool there, going to get clots, you're prone to getting strokes. So that's why you have to be on a anti-clotting agent. Any questions about that?
I don't know that it's about that, but what all does an implantable loop recorder take care of? What does it do?
She wanted to know what an implantable loop recorder does. If I'm remembering correctly, I think that one is the one that just measures what kind of rhythm you're having.
It's just looking, it's not doing.
Yeah, it's not
anything.
doing anything. It's just a diagnostic tool
Right. So,
to see what they want to see. Are you having atrial fib? Are you having SVT?
Okay,
what's going on. Because the treatments are different.
right, I think that's what I heard from you. Now I don't know how they were able to tell us. Is it one thing and not,
Did they put in a loop recorder in you?
they did,
Oh.
yeah. But at the time, you said that the treatment that they did by shocking me was not a usual treatment for whatever.
Yeah,
But then the next, I can't remember to tell you, there was something else, that they would use it for. There was a different kind of a situation that,
well, ventricular tachycardia.
yeah,
And sometimes if your heart's going that, she's asking about the difference between, ventricular tachycardia and an SVT. If your heart is going as fast as it was, the EKG, it's hard to distinguish sometimes ventricular tachycardia from an SVT. And even the cardiologists in the clinic, we would take them these strips and they'd have to get 2 or 3 of them would be measuring and examining. It's hard to tell. Yeah. Any other questions about atrial fib or? So I wanted to also say about the atrial fib, because Jane was asking about it. So if you get that little outpouching, there's a treatment called a Watchman that they, once again, it's not a big surgery. They don't open your chest. They just float in through your groin. It's like having a heart catheterization, and they go up into your left atrium. They find that appendage and they just block it off. It's like they put drywall in there. Put some drywall in, the blood can no longer get through into that appendage. That way the blood just keeps moving through. Not likely to get clots because you no longer have that appendage where it pools. And then many times you no longer need to be on blood thinners. Okay, the other common thing that you can have are called skipped beats, which is also kind of an irregular heartbeat, but it's not something that is continuous. You'll just have a little bloop here and a little bloop there. So sometimes if you're taking your pulse, sometimes I can feel them. I have PVCs. I can feel them when I'm having them. You'll just feel a little, might feel it in your chest. It's an early beat. PVC stands for premature ventricular contraction. You can also have premature atrial contractions, but they're not runs of anything. They're just a little beat occurs here and there. And those are, if they're just happening a beat here and a beat there, they're not dangerous. Okay. Any questions about anything? I didn't talk about all of the conduction problems because that's too much. That's a lot. There's a lot of them.
what an amazing organ we have in our
Isn't it? The heart's just amazing. And it's also amazing all the things that they can do now to keep us going. And not having to do open heart surgery for everything anymore. It's just all these little things, that catheters that they float in there now and put in valves and Watchman and clips. It's all
My
great.
dad died at 39 in his office of a heart attack. I know he had been having, what they call angina repeatedly. Uh, how couldn't they tell that he was going to have a heart attack?
They knew that he was having angina. They called it that.
I remember the term.
You know, it used to be that, I mean, now you come in with angina and, I mean, they just didn't do so many diagnostic tests in the past. They just waited and, they didn't do a heart cath like right off the bat, like they do now.
Okay.
Yeah. They just waited a lot longer. The diagnostic tests, they just didn't have, every hospital didn't have the ability to do all these things. But now most hospitals
Right.
have the ability to have a cath lab and have an echo lab and all
Wow.
that.
Okay.
Come a long way. Yeah. Yeah.
Amazing.
Yeah.
Thank you, Sharon.
You're welcome. Thanks for staying. John has a question.
Leaping back to
Repeat it.
pericarditis.
Yeah.
There was, when I changed, dental, some of the gum guy.
Yeah.
Periodontal,
Uh-huh.
they wanted to give me an antibiotic afterward
Yeah,
because they said
right.
if you get gum disease, it will go to your heart.
Yeah. One of the causes of pericarditis, I think it was listed, I didn't go through all of them, but
I didn't
is
see it on the list.
is gum disease. Because it's a whole inflammatory process in there, and it can cause that infection that you get in your gums can travel through the blood and get in the heart.
That was something where they were, for all new patients, they were routinely prescribing it, and I said, oh, I'd like to go through my cardiologist first. And we waived,
Uh-huh.
but that's something, and also, when I was a kid, I got a lot of strep throat.
Yes,
and they said
that's
same
another
thing.
cause. Yeah, untreated strep throat.
So that's-
And untreated strep throat can also cause valve disease.
So our presentation on Thursday is gonna be Bilal, our Gero student, on oral health, because he wants to
Oh.
be an oral surgeon.
Oh,
So it'll be curious to see what he's learned about,
how it relates to heart disease.
well, and if I'll have to make sure he talks about, prophylactic antibiotics, because it's pretty common,
Yeah,
and whether it's changed or not, I don't know, but lots of times people that have valve situations are directed to take antibiotics prior to dental work for the same reason that you were when you were doing whatever you were doing. And obviously, it's a sticky point for those of you that have to deal with dental stuff. Thank you, Sharon. Any other questions out there in Zoom land? Stop the recording. See you later.